So today's class is on another infectious disease we will start considering. This disease is called as diphtheria. Now we'll get into the details of the organism which causes the disease, but before that I would like to highlight a brief history of the disease. Now if we look in the ancient text, we can find diseases which have been described like diphtheria have been found in Babylonian and Sumerian history, even in Talmud. Hippocrates also had described this kind of a disease, and it is presumed that this disease actually arrived in the European continent from the Middle East. Another important aspect was that from the historical evidences, it suggests that this disease came in the, especially in the European context, in waves. That means after years, epidemic outbreaks were seen. Moving on into the early 16th century to the 18th century, this disease created an havoc, especially in the European scenario. This artistic representation by Goya shows a father trying to prevent a child from choking. Similarly, this is the classical representation where it is said the children are strangled by angels. Hence, this disease was also called as the strangling angel of children. Not many at that point of time why this disease occurred, but the most important feature of this disease was that many children were dying because of this disease. A very prominent cases can be seen in the European history with the death of the daughter of Queen Victoria, Alice. Her whole family was infected. She lost many of her children because of the disease. And perhaps the fatal case of the disease in her case was when she got infected from her own child. Both of them eventually succumbed to death. Another notable person who was infected was George Washington, thereby highlighting the transmission of disease from Europe to the American continents. Like many of the diseases prevalent at that point of time, like tuberculosis, the incidence of diphtheria increased with industrialization. Obviously, industrialization increased overcrowding, poverty, and lack of hygiene. Then came the breakthrough. Two notable scientists, Kleb and Loeffler. They were the initial people who were able to isolate the organism from patients' clinical sample. Okay. Now Loeffler, having isolated the organism, also gave the first probable pathology and pathogenesis of the disease, although not proved at that point of time. He hypothesized that this disease is because of toxemia, not due to the bacteria itself. Then, what is this organism? The organism that they were able to isolate was called the Corynebacterium, and because it caused diphtheria. Now, it is interesting to know the name diphtheria comes because of the characteristic lesion that it produces, which resembles leather or animal skin, also called as hide. Hence, it was named as diphtheria. So, this organism was then subsequently named as Corynebacterium diphtheriae, as it was causing diphtheria. Now, what is the features of this organism? This was a gram-positive organism, non-capsulated, non-sporing, non-motile, and it was a bacilli. A very important finding that this bacilli show was club-shaped swellings at the end of the bacteria. What was the very interesting finding of this bacteria was this club-shaped swelling at the end of the bacteria. Furthermore, these bacteria were present in a particular pattern. This pattern was called as cuneiform or called as the Chinese letter pattern. The reason was the bacteria was dividing in a snapping pattern. That is the reason why you will find L-shaped or V-shaped pattern. The next important finding was the presence of metachromatic granules at the present. Because of these granules, there was club-shaped swelling. These granules were also called as Babe's earnest granules. And with the use of methylene blue, we can easily observe this finding directly on the clinical sample. Later on, Andre Yersin and Pierre Roux, they conducted experiments on animals and proved that from the culture, if the organism was devoid of it, the extracts can also cause a similar disease. That means it proved the hypothesis given by Loeffler that this disease is not directly caused by the bacteria but because of the toxin. Hence, Von Wering and Kisato independently started working on the toxin, and they serially injected horses and other animals so that they could extract the antitoxin from these animals. This is a pictorial representation of how the antitoxin was developed during that period of time. And that point of time, this was the only effective therapy. Antidiphtheritic serum that was used for treatment of the patients. Many patients started recovering. Later on, Gaston Ramon, he took the toxin and inactivated it in formaldehyde to form what is known as toxoid. Toxoid means it's a toxin which have been neutralized, or it retains the antigenicity but does not have the effectivity to work as a toxin. Inactivated toxins are called toxoid. So he made what is called as diphtheria toxoid, and this was used for vaccination. The main target was the children to protect them from the disease itself. Hence, led to the discovery of what today we know as diphtheria toxoid. Later on, with the scientific evidence which showed that children were indeed protected by the toxoid vaccine, this was combined with other vaccines, including pertussis, tetanus, what we know today as DPT vaccines, and furthermore down the line, it was now called as the pentacell or pentavalent toxin combined with Haemophilus influenzae B and inactivated polio vaccine. Now that was all about the history. Now let us look at the disease itself. Now diphtheria presents in the form of classical diphtheria. Now what is classical diphtheria? The infection occurs through the respiratory route. It initially produces what is known as pharyngitis and tonsillitis. The route of infection is through inhalation. Now keep in mind, humans are the only reservoir of Corynebacterium diphtheria. That means if somebody gets infected, he or she is getting the infection from an existing case. After acquiring the infection, what happens is that this bacteria colonizes in the oral cavity, especially in the pharynx and in the tonsillar bed. There are many factors which helps in attachment of this bacteria to the mucosal membrane, including adhesions, hemagglutinin, and pili proteins like SPA-A to SPA-I. 9 pili proteins have been isolated. With the help of these, they adhere to the mucous membrane and the bacteria starts to proliferate. During proliferation of this bacteria, it starts producing a toxin called as the diphtheria toxin. This toxin is then absorbed through the mucous membrane. the cells of the mucous membrane gets affected because of the toxin and the bacterial growth, and they die. The resultant inflammatory response leads to secretion of fibrin and polymorphonuclear reaction. This seals off the colonized area with a whitish discoloration that we can see clinically, and this looks like a leather-like appearance. This is what is called as typical diphtheritic lesion. Now, why is this important? Because the commonly affected region is the pharynx and the tonsillar bed. When this membrane, although it's not a membrane, hence it is called as a pseudomembrane. Okay, it is not a true membrane, it is rather colonized bacteria with necrosed cells. This pseudomembrane can sometimes slough off. Whether it sloughs off or not, that will depend on the progression of the disease. The important highlighted part is that it may obstruct the respiratory passage. Hence, children may succumb to asphyxia. Sometimes this membrane may slough off, which will relieve the respiratory distress. And sometimes this membrane or the infection can progress from pharynx into the larynx and thereby increasing the respiratory distress even further. Another important aspect that you must understand is when the toxin is absorbed from this mucous membrane, it leads to the swelling in the regional lymph node. That is the jugular lymph node, the submandibular and the submental lymph node. This leads to what is called as bull neck appearance because of the lymphadenitis, that is inflammation of the lymph nodes. So clinically, most of the time you will find children with sore throat, sometimes with respiratory distress, hoarseness of voice will be the common complaint. On examining the oral cavity, you may find a reddish appearance, and if the disease has progressed further, you can find a whitish patches on the tonsillar bed and in the oropharynx. Along with that, you will have tender lymphadenitis. And this is the classical presentation. Now, let us try to understand the next important aspect. I have already told you the disease, most importantly, is caused by the toxin. Now, what is this toxin? So, diphtheria toxin has three parts. The first part binds with a receptor on the human cell. What is that receptor? It's the heparin binding epidermal growth factor. This is present in the mucous membrane of the oral cavity. So the toxin will bind with the cells and then it enters into the cell. Now you can see there are two parts, the A and the B. The A part helps in the uptake of the toxin into the endosome. Within the endosome, because of the presence of the high pH, I think you already know about how this endosome occurs. At high pH, the two fragments get separated, A and B. Now the A fragment, which is the active fragment, when it gets separated from the B fragment, will inhibit this ribosylation process of the elongating factor 2, where the NAD is converted to nicotinamide. What will this lead to? It will lead to inhibition of protein synthesis. Keep in mind, almost all cells are undergoing continuous protein synthesis, which keeps the cell alive. If the protein synthesis is inhibited, the cell will die. Now, this will affect virtually all types of cell. But I have already told you it binds with particular receptor, that is heparin binding epidermal growth factor. This growth factor is seen more commonly in predominantly two types of cells as far as you people are concerned. Most important will be cardiac myocytes and the neuronal cells. Hence, the effect of the toxin will be predominantly seen in case of cardiac myocyte, that is the heart and the nerves. What will be the effect? It will lead to, in the heart, it may lead to arrhythmias, conduction abnormalities, and cardiomyopathy. Okay. And what will happen to the neurons? It will lead to paresis. Okay. It will start from the local region. Hence, children are more susceptible to local paresis. It will lead to non-functioning of the soft palate. Hence, the child cannot deglute. Secretions can regurgitate and may lead to aspiration of own respiratory secretions. Furthermore, if the disease progresses, other neuronal features may be seen, including cranial nerve palsy. Now, having said that, you must understand, if the patient is indeed infected with corynebacteria, that is, the patient is having diphtheria, the patient must be kept at rest, because the toxin will affect the cardiac myocytes and the patient may undergo into heart failure if the patient is agitated or excited. Now, please remember, diphtheria is a toxemia. That is the most important thing you should understand today. It is a toxemia foremost. It is never a bacteria. The bacteria never enters into the bloodstream. The bacteria resides only in the local region. There are some corynebacterial infections in which it enters into the bloodstream, but that's a discussion for later on. Another presentation that can be seen, especially in the tropical and the subtropical region, is cutaneous diphtheria. Well, as the name suggests, cutaneous diphtheria means the infection occurs on the skin. The infection is generally acquired from respiratory droplets or direct contact into the skin. Hence, the lesions can be commonly found on face, arms, and legs. It starts with a small pustule which ruptures and it becomes a non healing ulcer. Sometimes we can find a leather like appearance on the non healing ulcer, and if that is removed, we can see a reddish ulcer bed. It takes a lot of time, from 3 months to 6 months, for this ulcer to heal. Similar to faucial diphtheria, cutaneous diphtheria also leads to toxemia, absorption of the toxin from the wound into the systemic circulation. Why this is important? Because as of today, vaccination with diphtheria toxoid is almost universal. Cases of classical diphtheria has indeed decreased, but in our country and in other tropical or subtropical countries, cases of cutaneous diphtheria are increasing. Now, next comes the question, what we need to do if we do indeed find a case that is suggestive of diphtheria. First, we need to take the clinical sample. Now, when you find this kind of lesions, that is oral regions, where we can find whitish discoloration or patches, we can take a swab sample, or if indeed required, we can take a biopsy and look it under the microscope with histopathological examination. The other way around is to take the swab and then we may directly look into the microscope with the help of Albert stain, where we look for what? Metachromatic granules, gram positive bacilli with granules. If that we can see, we can say it is suggestive of diphtheria. However, for confirmation, we need to isolate that. For that, we need to go for culture. Culture can be done on sheep or horse blood agar or in selective like potassium tellurite agar. Now, one very important aspect is that you must understand This bacteria produces the toxin because of a particular gene. But this gene is not an inherited gene of this bacteria. That means it is not present universally. Rather, this gene is being transferred from one bacteria to the other with the help of a virus, a bacteriophage. In this case, it will be called as choriophage. Now, this virus transfers this gene. This gene is called tox gene into the bacteria. So, if a particular bacteria does indeed have this gene, it will produce toxin. Otherwise, it will fail to produce the toxin. Now, corynebacteria, other diphtheria and other coroniform bacteria like other bacilli are commensals of the skin. So, they are also present in the nasal cavity. So, just by microscopy, we cannot discern whether it is indeed Corynebacterium diphtheria or not and whether it is actually producing toxin or not. So, what we need to do? We need to confirm that this bacteria is indeed Corynebacterium diphtheria, not other coroniform, and if it is indeed Corynebacterium diphtheria, whether it is producing toxin or not. This is what we need to prove. Now, for culture, we can use blood agar and selective media like potassium telluride agar, which will do indeed help us identify whether this particular bacteria is diphtheria or not. Furthermore, we can use multitop or PCR for identification of the organism. Again, PCR is extremely helpful if we are trying to look for the presence or absence of this tox gene. That is very important. Other way around, we can go and test with immunological methods to see the presence or absence of the toxin itself. Okay, we can use various methods including ELISA or enzymatic methods, or we can even use animal experiment, that is called as toxigenicity testing. This is the protocol that we need to follow. So, what will be the sample? Commonly in case of classical diphtheria, the sample will be a throat swab or a portion of the pseudomembrane. Please remember, this is not a true membrane, it is a pseudomembrane. Then directly we can look in the Gram strain or the Albert strain. If it is suggestive, we need to culture. Commonly, we can use non-selective culture media like a blood agar or a low flow serum slope, or we can use selective media like potassium telluride agar, which shows black colored colonies. Next, we need to identify whether it is indeed Corynebacterium diphtheria or not. We can go with the classical methods like fermentation of sugars testing, or we can use the rapid automated methods including Multitop or Vitek. Then comes the demonstration of toxin. We can demonstrate by the presence of the toxin with LX gel precipitation test, or immunochromatography or ELISA, or by PCR, or demonstration of cytotoxicity on cell lines. Now, this is a picture shows LX gel precipitation test. Now, let me explain it to you. There are two methods. This is the original method, this is the modified method. Now, on this petri dish, the agar media, this strip, if you can see, is a filter paper which contains the antitoxin. Okay, and perpendicular to this field, we are streaking the organisms along with the controls and the test. This is the test and these are the controls. Now, try to look what happens. Now, look at this positive control. The organism grows over here. The toxin is produced, the antitoxin is neutralized. Can you see this faint band? This is the band of neutralization. Similarly, now you look at a negative control, you won't see this kind of band over here because this strain is not producing the toxin. Now, let us look at the test sample. This is the test sample, this band is being produced. Similarly, in this modified version, the disc contains the antitoxin and the test strains are tested over here along with the controls. Now, you can see the positive controls all have this band. This is the band where the toxin, antitoxin reacts. But in the negative control, you can see there is no band. So this is one of the earliest methods which demonstrated the presence of toxin producing bacteria. Now, why do we need to go through all this? First, we need to confirm the diagnosis, not only for the management of the patient, but also for the epidemiological diagnosis, because it may lead to an outbreak. Next, also we need to do for biotyping. Now, Corynebacterium diphtheria has 4 biotypes. Biotypes means same bacteria, but some differences are there. This is called biotypes. The 4 biotypes are gravis, mitis, intermedius, and belfanti. Originally, 3 biotypes were identified: gravis, intermedius, and mitis. Gravis means severe diseases. It used to call severe disease, so it's called gravis. Mitis, not so severe, and intermediate level. Later on, another strain was found. It is called as belfanti. Now, coming to the epidemiological part, I've already told you Corynebacteria are commensal of the skin. They colonize the nose. Hence, even in spite of vaccination, people will have colonized bacteria in the nasal cavity. Vaccination will not prevent colonization. Okay. So, another aspect is that a very small but a significant fraction of the patients will have the disease but will be asymptomatic. The symptoms start to show about 2 to 5 days, but the patient remains infective for about 2 to 3 weeks. Now, if you understand this fact, then you will realize these are the real carriers of the disease. People who do not show signs and symptoms, the asymptomatic ones, and the people who, even if they do show signs and symptoms, they remain infective for about 2 to 3 weeks, even in spite treatment. So these are the people who are the carriers. Now, when I've said that they can spread the disease or they remain infective for this long period, now you can understand why isolation of the patients is so important. Now, commonly earlier it was seen that disease used to occur in children 1 to 5 years. But this epidemiology has changed over the years. Because of the increased vaccination coverage, less number of children are now affected. People who are affected more commonly are the children of an older age, that is between the age 15 to 15 and above, and elderly, that is 60 and above. The reason is probably because of the waning immunity in the elderly. They are vaccinated in their childhood. Thereafter, the vaccination is not given, the immune status drops, and they can get the disease. Now, globally, during the period after the post Second World War, with the help of the vaccination, the incidence of the disease decreased rapidly. It decreased rapidly to such an extent that on today's viewpoint, diphtheria is not so significant now. But over the last 10 to 15 years, we are observing a resurgence of this disease worldwide. Not only in India, but also worldwide. We'll discuss it a little later. Okay, in India, resurgence have been seen in Tamil Nadu, Kerala, and Karnataka, and in many of the areas also, many times the studies are not being done. Now, coming to the treatment. So, what would be the treatment? Just try to understand this. What would be treatment? If a patient does get infected, what we need to do? The first part is it's a toxemia. So we need to treat the toxin that is already present in the body, that has been already absorbed from the infected areas, and we need to stop the production of the toxin further. How can we do so? First is we need to give antitoxin. That is the toxin which has already entered into the bloodstream. We need to neutralize that. For that, we need to give anti-diphtheritic serum. Basically, it's an immunoglobulin which will bind with the toxin and neutralize them. WHO has recommended the dose of the antitoxin depending on the duration of illness and the extent of illness. Okay. So WHO has recommended. Okay. Next, very important part is use of antibiotics for therapy. Now, the role of antibiotics in this case is twofold. First part is we need to kill the bacteria that is already present, and also we need to stop the production of toxin. So, hence it is recommended that we use a protein synthesis inhibitor which will inhibit the protein synthesis in the bacteria. Bacteria produces a toxin, the toxin is a type of protein, we need to inhibit the protein synthesis. Furthermore, we need to give an antibiotic which can rapidly kill the bacteria. Because it's a gram positive bacteria which have a bigger cell wall, and so cell wall acting antibiotics will act well. Penicillin group of drug acts very well. Resistance is rarely seen. However, there are some reports, but nevertheless, still it is a very effective drug. Similarly, we need to give prophylaxis to the people who will come in contact with this patient, be it the healthcare workers treating the patient or the family members of the patient. What we can do, we can give erythromycin, and we can also give vaccine if the person is not previously vaccinated. Effective vaccine is any titer more than 0.01. Now, regarding the vaccine, I have already told you now pentavalent vaccines are available, but importantly you must understand there are two types of vaccine. One is called TD and the DPT itself. Now, what is TD? TD is that vaccine in which it has got tetanus toxoid along with diphtheria toxoid, and it has got a lower dose and it is used for adults. The DPT has 25 LF units. LF is limit of flocculation, and TD contains only 2 LF units. Hence, all adults must be given a booster dose of TD, small d, that is the lower dose, every 10 years. Otherwise, people will lose their vaccine status and elderly people will get infected. Okay. The National Immunization Schedule says at least 5 doses of the DPT vaccine must be given at 0, 6 and 14 weeks after birth. 6, 10 and 14 weeks. Booster doses are to be given at 6 to 24 months and at 5 years, that is the age of entry into the school. Well, rest of the details I think you have read already. As for the adults, the TD vaccine should be given to all adults more than 18 years and boosted every 10 years till the age of 65 years. Now, coming to the last part, another terminology you must be acquainted with is called as diphtheroids. What are diphtheroids? Diphtheroids are all those other corynebacteria which resemble Corynebacterium diphtheria but are not Corynebacterium diphtheria. These are also called coryneiform bacteria. They are non-diphtheritic and they are commensals of throat, skin and conjunctiva. They are present in virtually all human beings. So, whenever you are trying to test for diphtheria, keep these in mind. If you are not advising a proper microbiological investigation, you will end up getting false positive reports because of this bacteria. And another important part is whenever you do suspect a patient with diphtheria, always inform the laboratory that you are advising for any investigation that this patient is suspected of being diphtheria, because it is a highly infectious case and it needs a, although not regularly used, a different set of investigative apparatus for doing the investigation, be it a culture media or stains. So the point is you need to inform the laboratory before sending. Okay, unlike other cases. Now, regarding the resurgence, I told you I'll come to it later. Another important thing that was seen is that this tox gene that I've already told you, which is responsible for production of the toxin, is also seen in other corynebacteria like Corynebacterium ulcerans and pseudotuberculosis. Now, these two species generally do not cause human beings infections in human beings. However, they do cause infections in animals, especially in cows, cats, dogs. Why this is important? Because although Corynebacterium diphtheria, the sole reservoir is human beings, this gene can be transferred from a tox plus, that is a Corynebacterium ulcerans or pseudotuberculosis containing the toxin producing gene, and may be transferred into the Corynebacterium diphtheria without the gene in human beings. That means the tox gene may be transferred from these species to the Corynebacterium diphtheria. Okay. So even though the sole reservoir is human being, the transmission can occur because of these other infections. Okay. Now finally, if we look at this picture, it shows the flow chart showing how this disease has progressed from say 1600 to till today's date. So you can see in 1613 a large diphtheric epidemic was seen, which spread throughout the European continent, including and even spread into the American continents. Then Pierre Bretonneau first described the disease and gave the disease name as diphtheria because it resembles the hide. Kleb and Loeffler identified the organism. Thereafter, antitoxin serum was developed, and William H. Park developed a particular strain of this bacteria from which the toxoid vaccine was later on developed. This is called as the Park-William number 8 strain. Thereafter, the number of the cases decreased in the view of the World War. Initially increased, then decreased after the World War. Combined DPT vaccination was being started, given worldwide. WHO then advocated for including DPT vaccine in childhood vaccination. Thereafter, the incidence decreased till now. But right from 2006 to 2019, we can see diphtheria epidemic reported in many countries, even in India. If we look at the image over here, it shows the world map along with the color of the DPT coverage. Now, it's very important to see the Indian context. In the Indian context, we can see the DPT coverage is more than 90%. Yet, we can find that the number of cases in the year 2018 were till 2018, 8,788 cases have been reported. So, this is the reason why it is seen that this disease is coming back, or a re emergence of the disease is being seen. Okay.